be discussing the INICET MDS November 2024 paper. Okay. So I hope I am connected. Both audio and visuals are fair enough. Let us start today's session. I hope the questions are clearly visible on your screen. Question number 1, as displayed, is which of the following statements is true regarding post-space preparation? So I would say that recently a lot of questions have come in the examinations, both your INICET and your other examinations regarding these technical aspects of the post-endodontic restorations like post-encore, etc. And it is one of the questions that has come recently, last year only. True regarding post-space preparation, which is true. Okay. An end cutting burr is used for post-space preparation. Okay. Is this a statement true? If we look at the option that what we use for post-space preparation, the instrument used is piezo reamer. All of you know that. Piezo reamer is an instrument that is shaped and has a head like this, an elongated head, and this head is usually non-cutting. Okay, why it is non-cutting? Because the purpose is to go through the root canal, follow the path of the root canal, and simply remove the gattapacha points without any reduction of the root canal or transporting the passage of the root canal. So what we use, there is a non-cutting head. It is saying an end cutting burr is used. No, this option would be wrong. Coming over to option number 2, increasing the diameter increases the retention and is the recommended method to enhance the retention. Now this option has got two parts, that increasing the diameter increases the retention. Yes, this is partially true. The thicker the post, the more easily it is retained inside the root canals. But the second part says, is the recommended method to enhance the retention? No. So this option is not fully correct. The reason is correct, but assertion that is it is the recommended method is not correct, because the most highly recommended method to increase the retention of post inside the root canal is to increase the length of the post, not the diameter of the post. Because as we increase the diameter of the post, only a subtle increase in the retention occurs, but the fracture potential of the root increases because all the forces are transmitted to the root and the surrounding dentine is not adequately thick enough to support the loads. So what is the recommended method is to increase the length of the post. So this option also is not correct. Coming over to option number 3, the depth of the post should be kept as minimum as possible. Now this obviously contradicts what I have told you, that what is the recommended method? You have to increase the length of the post. So definitely the depth of the post should be kept at maximum, not minimum. This option is also incorrect. Now coming over to option number 4, that is for molars, caution is needed when preparing the distal aspect of the mesial root and distal aspect of the distal root due to possible concavities. Now this is related to the anatomical structure. If we talk about a mandibular molar, suppose, which has got anatomy like this, curved mesial root and a straight distal root, then whenever these curvatures are encountered on the distal aspects, we have to be careful that excessive reduction of the dentine should not be there. Otherwise, what would happen? There would be perforation in the wall of the root canal. So option 4 is correct out of the options given over here. Answer would be option 4. So you have to, in summary, you have to remember that to increase the retention of the post, the most recommended method is to increase the length of the post. The post should be as long as possible for any given clinical situation. Option number 2. Which of the following is correct when bypassing a broken instrument with a stainless steel file during endodontic treatment? Bypassing a separated or broken instrument. Okay. Now, options given are use a smaller file with gentle watch winding and up and down motion to negotiate around the broken fragment. Suppose this is a root canal. This is another clinically oriented topic. Suppose a file is separated inside the root canal at somewhere here. This is a separated file. Now we have to bypass it. What are the rules to follow it? Use a smaller file with gentle watch winding and up and down motions to negotiate around the broken instrument. Definitely, we would insert a small file. Why a small file? Because a small file means whose diameter is less. Suppose number 10, number 15K file we would be using, which is easy to negotiate through the small spaces around the separated instrument. So definitely we will be using a small file is correct. A smaller file is used and gentle watch winding and up and down motion. So suppose this is a file, watch winding motion is to and fro motion, clockwise, counterclockwise motion, and up and down motion. We just feel the wall of the root canal. We feel the instrument with the file tip and try to bypass it. So this option is definitely correct. Now look at the other options. We apply ultrasonic vibration in linear motion to directly dislodge the broken instrument. Okay. Ultrasonic vibration in linear motion. Linear motion means up and down motion. No, the ultrasonic tip is applied onto the inner curvature, inner side of the root side. So ultrasonic tip is applied on inner side and not in a linear motion, inner side of separated instrument. Okay. As you have to remember that inner side of the separated instrument. Enlarge the coronal portion of the canal with filing or reaming motion to facilitate bypassing. Now, this option to enlarge the coronal aspect is used for instrument retrieval. Whenever we are attempting to retrieve a separated instrument from the root canal, we would follow this, that we would enlarge the coronal aspect of the root canal with the help of larger instruments like GG drills to gain access to the separated instrument. But here in the question, it is asking you about bypassing the broken file and not retrieving the broken file. So this option is not correct. Option 2 is also not correct. Okay. So please do not get confused. Option 3 is a correct method for instrument retrieval and not for bypassing the instrument. And avoid using lubricants and rely on rotational motions for better control. This is obviously not correct because we have to definitely use a lot of fluid irrigation, lot of irrigants, lot of lubricants are used so that whatever debris is being generated is flushed out from the root canal and bypassing the instrument becomes easier. So whenever we are working in dry root canals in any given clinical situation, the procedures are not accomplished properly. So this option is also correct, not incorrect. So what would be the answer? Answer would be option 1, that for bypassing the instrument, we first attempt with a small instrument in small watch winding or up and down motions, try to gain a catch point and then proceed downward. Question number 3. Identify the burr shown in the image. Now, I think this should be easy to answer for everyone. What is this burr? This burr is a truncated cone burr. The shape of the burr is called truncated cone burr. Truncated means it is an inverted cone burr with rounded corners. That's why it is called truncated cone burr and it is used for amalgam tooth preparations. This type of burr is used for amalgam tooth preparations. And number 271 burr, number 169L burr, number 245 or number 330 burr. This burr is the principal burr that is used for amalgam tooth preparations. answer would be option number 3. This burr has a head length of 3 mm and a diameter of 0.8 millimeters. Number 271 burr is used for inlay cast metal tooth preparations. Okay. And number 271 burr would be having shape like this. It is a flat-ended, plain-cut, tapered fissure burr. Flat-ended, plain-cut, tapered fissure burr. The dimensions are the same as number 245 burr. Length would be 3 millimeters and the diameter of the head would be 0.8 millimeters. You can see a distinct difference in the shape of the two burrs. Number 169 L burr is also a tapered fissure, small burr. It is a small tapered fissure burr. It would be something again the shape of like 271 burr, but it is a small tapered fissure burr with a diameter of 0.5 millimeter. The diameter is 0.5 millimeter. And what is the use of 169 L burr? It is used for placement of retentive grooves. We know that retentive grooves are placed both for amalgam tooth preparation as well as for cast metal tooth preparations into the exiolingual and exiofacial line angles. And number 330 burr is a small pear-shaped burr. It is a small pear-shaped burr. So number 330 burr would be something like this. A very small pear-shaped burr. Okay. You know what is a pear? Pear is a fruit. So it is a small pear-shaped burr and this is used for the most conservative amalgam tooth preparation. Number 330 burr. Okay. So I have shown you the shapes of all the 4 options given. And what is asked in the question is number 245 burr that is used for amalgam tooth preparations. Okay. Coming over to question number 4. All of the following goals of regenerative endodontic procedures, all of the following are the goals except which is not the goal for the regenerative endodontic procedures. Let us see the options. Elimination of clinical signs and symptoms, increase in length and canal diameter, positive pulp vitality response, and complete obliteration of the root canal. What is not an option? See, regenerative endodontic procedures, all of you must be knowing, they are the contemporary treatment for immature pulpless teeth. For immature pulpless teeth. Okay, so immature tooth, that is a non-vital tooth with open apex. We attempt regenerative endodontic procedures. The conventional treatment has been epexification with either calcium hydroxide or more favorably with MTA. So in REPs, what do we aim to attain? We aim to attain elimination of clinical signs and symptoms. Is true, is correct. Increase in root length and canal diameter. Yes, because it is a biologically based procedure. In contrast to epexification, where simply an apical barrier is created, here it is a biological based procedure and we aim to achieve not only increase in length, that is apexogenesis, but as well as increase in diameter of the root canal walls. Positive pulp vitality response, definitely. We call it regenerative endodontic. So the ideal clinical situation would be that a pulpless tooth has got regeneration of pulp and there is positive pulp vitality test. And complete obliteration of the root canal, that is definitely not the desirable outcome. So option 4 would be the answer. Other desirable outcomes for regenerative endodontic procedures are These three are definitely there. Other ones are resolution of periapical lesion. Simply we would call resolution of periapical pathology and root end closure. These are the 5 principal objectives that we aim to attain through regenerative endodontic procedures. The easiest one are resolution of clinical signs and symptoms. Okay, they are called the patient-centric symptoms. Patient-centric means when the patient seeks treatment to resolution of the pain or any symptoms associated. Okay, the patient is not concerned with the root length. The patient is not concerned with the diameter of the roots. The patient is simply concerned that whatever pain or other symptoms are associated should be relieved. So, elimination of clinical sign and symptoms is one of the first things that we attain, and they are the easiest to achieve with regenerative endodontic procedures. Then, as a clinician, resolution of periapical pathology, root end closure, and increase in root length and diameter. These 3 objectives, they are clinician-centric objectives. They come in the next higher hierarchy. And the most difficult to achieve is regeneration of the pulp and positive pulp vitality. So if we have to list the hierarchy of achievable results, we can talk about patient-centric results, that is resolution of pain, swelling, and whatever symptoms are there. Clinician-centric results, that is increased root length and diameter, resolution of periapical lesion and root end closure. And then scientific results. Scientific means, or we can say research oriented results, are the positive pulp vitality response. So 1, 2, and 3, they can be represented in the form of a pyramid. The base forms the patient-centric, the middle portion is the clinician-centric, and the topmost are the research or the scientific-centric results that we obtain from regenerative endodontic procedures. They are the most difficult to attain. They are the most easy to attain. Coming over to question number 5. According to WHO classification, what does KO 4.4 represent? Now, basically, this code is given for some periapical lesions. KO 4.4 represents acute apical periodontitis. Okay, this is something that you have to remember. The codes start from KO 4.4, acute apical periodontitis. Then code KO 4.5 represents chronic apical periodontitis. KO 4.4, acute apical periodontitis. KO 4.6 represents apical abscess with sinus formation. We know that whenever there is a periapical lesion, abscess formation in a tooth, if it is a long-standing one, it forms a sinus. So we give the code 4.6. It is subdivided into 4.60 whenever the sinus forms to maxillary antrum. Okay, in the maxillary air sinus, maxillary antrum, the opening of the sinus is there. Code 4.60 is given. 4.61, when the sinus forms to floor of the nasal cavity. Opening of the sinus means what are the locations, anatomic locations for the drainage of the sinus tract. Code 4.62, when the sinus forms into the oral vestibule. And this is the most common area where the sinus formation occurs. And 4.63, when the sinus forms on outer skin of the face. There's outside the oral cavity on the skin, the sinus formation occurs. Okay. Then we have code 4.7 that is used for abscess without sinus. Okay. And finally, code 4.8 This is used for periapical cyst. Periapical cyst. Okay. It is further divided into code 4.80 for radicular cyst that is associated with the root of the tooth. Code 4.80 for residual cyst and 4.81 for inflammatory periodontal cyst. So starting from KO 4.4, 4.5, 4.6, 4.7 and 4.8, these are the codes for WHO classification of periapical lesions with the subcodes over here. So what does KO 4.4 represents? It represents acute apical periodontitis. Option 4 would be the answer. Okay. Coming over to question number 6. In lateral condensation of Gattaparcha, the spreader should ideally reach to the radiographic working length, 0.5 to 1 millimeter short of the working length, 1 to 2 millimeter short of the working length, or to the anatomical working length. Now, where do we use a spreader? A spreader is used in cold lateral compaction of the root canals. Okay, and this is something that you have to remember, that we select a spreader that fits 1 to 2 millimeter short of the working length. Option 3 would be the answer. Cold lateral compaction. So this is the root canal that is being obturated. This is the master cone of Gattaparcha that sits positively at the apical 1/3 of the root canal to the prepared working length, and then we select a spreader. The spreader is a smooth and tapered instrument with a pointed tip, and this spreader should reach 1 to 2 millimeter short of working length. Because if it reaches to the working length, the pointed tip of the spreader would penetrate the master cone and can dislodge the master cone coronally or apically. Okay, we want only the master cone to be well fitted and snugly seated at the prepared working length. That's why we keep the spreader 1 to 2 millimeters short of working length. Option 3 would be the answer. Coming over to the next question. Question number 7. Which of the following is commonly used as a hemostatic agent in vital pulp therapy? Hemostatic agent means it prevents the blood flow, or it is a blood clotting agent. Sodium hypochlorite, chlorhexidine, saline, or calcium hydroxide. I think there should be no difficulty in answering this question. Answer would be option 1, sodium hypochlorite. It is used in vital pulp therapy. What does vital pulp therapy involve? It involves procedures like direct and indirect pulp capping and your pulpotomy procedures. And vital pulp therapy is done in asymptomatic patients. Because we are wanting to preserve the vitality of the radicular pulp, it is done in asymptomatic patients with reversible pulpitis. Then only we would be able to save the radicular pulp. So, what is reversible pulpitis? Reversible pulpitis means there is inflammation of the pulp, but the bleeding from the pulp can be controlled with a 5 to 10 minute application of sodium hypochlorite. If even after that period, sodium hypochlorite is not able to control the bleeding, there's continuous bleeding from the pulp, it means it is irreversibly inflamed pulp and vital pulp therapy is no longer indicated. So these are the two important clinical situations that help you in deciding whether you have to go for vital pulp therapy or pulpectomy. And out of the agents, definitely sodium hypochlorite is used in the concentration of 3 to 5.25% usually. Okay. Question number 8. All of the following are ideal properties of root filling material except root filling material, it is asking you. Obturating material does not resolve, slightly contracts after setting, easy to remove if necessary, and non-toxic to periapical tissues. What do you think? It should not resolve. Ideal properties of root and filling material except, yes, definitely, it should be permanently sealing the tooth that we have obturated. Here, please do not get confused with, it is not asking you about the treatment of primary teeth where we want the filling material to resolve along with the tooth. It is simply talking about regular root canal treatment of a mature tooth. The filling material should not resolve. It should slightly contract after setting. If this is the wall of the root canal and this is the filling material, if it would contract on setting, like your zinc oxide eugenol sealers, there would be a microscopic gap between the wall of the root canal and there are chances of micro leakage. The material would be pulled off from the walls of the root canal because it is undergoing setting contraction. There would be micro leakage and it can lead to failure of the root canal. But definitely slight contraction is not desirable. What is desirable? Slight expansion of the material. If we talk about certain contemporary filling materials like calcium silicate based materials, they undergo slight expansion of about 0.1 to 0.4%. Look at the other options. It should be easy to remove if necessary. Definitely yes. Each and every material should be conducive to retreatment because failure can occur. There is always a potential. And if we are using a material that cannot be retrieved, then the tooth is doomed to failure. It should be non-toxic to periapical tissues, but obvious. So what would be the answer? This is not desirable. Slight contraction after setting. Coming over to question number 9. In microsurgical endodontics, root end preparation using ultrasonics is typically performed with root end preparation using ultrasonics. High power with coolant, low power and no water coolant, high power and no water coolant, and low power and water coolant. What would be the answer? Means it is talking about root and tooth preparation with an ultrasonic tip. This is an ultrasonic tip attached to an ultrasonic handpiece that is being used to prepare the root end. We definitely use low power. We are not doing scaling and root planing. We are using preparation of the root and tooth in a small, thin area of the tooth. So low power is used so that it minimizes the fracture potential. Due to ultrasonic vibration, the thin walls of the root, they can develop fractures. Okay, that's why we always use low setting, and to dissipate the heat that is generated, definitely we use water coolant. Water coolant would be required to dissipate the heat generated so that thermal damage to the periapical tissues does not occur. So what would be the answer? Low power with water coolant, option 4 would be the answer. Okay. I was telling about why we do not use high power because there are chances of developing root end fractures. Okay. There are 3 types of fractures that can develop whenever we do root and tooth preparation with ultrasonics. Fractures of 3 types can develop. This is the resected root end where we are doing the root end preparation. In one situation, the fracture can develop on the outer aspect and tend to extend inward. In another situation, the fracture can develop in the wall of the root canal and tend to extend outward. And in third situation, there can be a through and through fracture. So these three type of fractures in the root end can occur whenever we are using high setting of the ultrasonic root end preparations. These are called extracanal fractures. These are called intracanal fractures, and these are called communicating fractures. Okay, through and through communicating fractures. Three types of fractures can occur. To avoid them, we use ultrasonics. And how ultrasonic is advantages? Advantage of ultrasonic is that it is easier access. For root end preparation, we use ultrasonics, lasers, or bursts. Advantages of ultrasonics are that they have got easier access. A small window is required, and because they are bent at various degrees, it is easy to prepare the root end. Second advantage is it has low generation of smear layer. Okay, but the disadvantage of ultrasonics is root end preparation is potential for development of root end fractures. Okay, coming over to question number 10. Which of the following is commonly used as the initial irrigant in cases of acute apical pulpal abscess? Only saline, warm saline, 2.5% sodium hypochlorite or 5% sodium hypochlorite. Now this question, although has got no scientific evidence, remember what I am telling you. This question has got no scientific evidence and validity that in cases of acute pulpal abscess or apical abscess, what irrigant should be used first. But this question has come several times, especially in your AIIMS and other INICET examinations. And the thing that you have to remember that warm saline is used. Okay. There's again, I am telling you, there is no scientific evidence or logical reasoning why we would be using a saline for flushing the root canals in cases of apical abscess. This is something that you have to just remember, that if you're sitting for your INICET examination and you get a question like this, you have to mark the answer as option number 2, saline as compared to sodium hypochlorite. Otherwise, technically speaking, sodium hypochlorite should be used and is routinely used. I hope I am clear with what I am telling you. Okay, so that's why there is no explanation to this question. It is something that has been coming over the years through these examinations. Okay. Question number 11. According to IADT 2020 guidelines for traumatic dental injuries without alveolar bone fracture, okay, which of the following statements about splinting duration is incorrect? Now again, traumatology, one of the favorite topics for INICET examinations. So do not get confused according to IADT 2020 guidelines, because the guidelines are definitely evolved and whatever they are asking you are related to the latest guidelines only. For traumatic dental injuries without alveolar bone fracture means there's the tooth supporting bone. This is the tooth placed in the bone and the tooth supporting bone is intact. The bone is intact, no alveolar bone fracture is there. Which of the following statements is incorrect about the duration? Lateral luxation, splint for 2 weeks. Avulsion, splint for 2 weeks. Extrusion, splint for 2 weeks. And intrusion, splint for 4 weeks. Now, I think there should be no difficulty in answering this question. Okay. See, previously also we have discussed this. Again, I would be summarizing. Duration of splinting is important. luxation injuries. If we talk about concussion does not require any form of splinting. Subluxation requires 2 weeks. Extrusion requires 2 weeks of semi-rigid or physiological splinting. Lateral luxation and intrusion, which are the more severe forms of luxation, they require splinting for 4 weeks. And avulsion of the tooth, it requires 1 to 2 weeks of splinting. These are the splinting durations for your luxation injuries and your avulsion injuries, and the intrusion is the most severe form of luxation injury. 2 weeks, 4 weeks, and 1 to 2 weeks all are semi-rigid physiological splinting. If the question is asking you avulsion with alveolar bone fracture, then avulsion with alveolar bone fracture. It would be 6 to 8 weeks. So related to avulsion, there can be 2 clinical situations: without alveolar bone fracture and with alveolar bone fracture. The duration ranges from this to this. Okay. So here lateral luxation 2 weeks is incorrect. It would be 4 weeks. Avulsion 1 to 2 weeks is correct. Extrusion 2 weeks and intrusion 4 weeks is correct. So what would be the answer? Option 1. Okay. If you simply remember this much, you will be able to answer all the questions related to your splinting. And always remember, it is always non-rigid, physiological or flexible splint that we employ in all the clinical situations. Question number 12. Which of the following is not true regarding post-space preparation? Another question related to. It should extend at least 4 mm apical to the alveolar crest to minimize the dentinal stress. In average length roots, the post should allow for 5 mm of apical plug of gutta percha and should either touch or extend right up to the gutta percha. In molar roots, it should extend up to 7 mm into the canal from the pulp chamber floor. In an average rooted tooth, it should extend into the canal by 1/3 of the root length. Now, this is something that is technical, and this was a very good question related to the in-depth knowledge. Now, it talk about post situations. I have already told you that the post should be as long as possible. Okay. Now, there can be an anterior tooth and posterior tooth, like a molar. So suppose this is a tooth, a broken down tooth. This is the crest of the alveolar bone. Then a general norm is that whatever post we choose, this is a line drawn through the crest of the alveolar bone. Whatever post we place, it should extend at least 4 mm apical to crest of the bone. This is one general norm that we follow. And how do we see this? We see this with the help of a radiograph. We would measure the crest of the alveolar bone, and the post in any clinical situation should be at least, this is not maximum, it is the minimum depth of the post below the crest of alveolar bone. So option 1 is correct. In average length roots, the post should allow apical 5 mm of gutta percha. That is also correct because 5 mm of the apical gutta percha seal is recommended. The range is 4 to 5 mm. Okay, absolute minimum is 3 mm. What is this dimension? This is how much of the gutta percha should be left inside the root canal. Absolute minimum, the question would be asking you specifically. If the question is simply asking you what should be the length of the apical gutta percha, range is 4 to 5 mm. If 4 mm and 5 mm are separate options, stick to 5 mm as given here. So option number 2 is also correct. In molar roots, the post should extend up to 7 millimeter from the canal to the pulp chamber floor. Now, this is something technical that you have to remember. Suppose this is a molar that we are planning to place. Suppose this is the orifice of the root canal. Then this is the total length of the post that we have selected. And for molars, it is a norm that the maximum length of post below the root canal orifice should be 7 millimeter. This is maximum. It is not telling you from the crest of the alveolar bone. It is telling you that it is neither the length of the post. The total length of the post is different. What I am telling you, that the length of the post that extends below the root canal orifice in a posterior tooth like molar should be maximum 7 millimeter, because it is an anatomical phenomena that in majority of the tooth roots beyond 7 millimeters root canal curvatures are found, and post is always placed in the straight portion of the root canal. So this option is also correct. I would say this was a very good question, very technically oriented. In an average rooted tooth, it should extend into the canal by 1/3 of the root length. We already know post should be as long as possible. It should be 2/3 to 3/4 of 3/4 of root length. As long as possible. So this option is not correct. Fourth option would be the answer. Okay, so this dimension 4 millimeter is the minimum dimension below the crest of alveolar bone. 7 millimeter is the maximum dimension below the root canal orifice. So two distinct landmarks are there: root canal orifice for posterior teeth and the crest of the alveolar bone. From crest of the alveolar bone, the minimum extension of the post should be 4 millimeter. From root canal orifice, the maximum extension of the post should be 7 millimeter, and that is applicable only for molars. Okay. You do not go with this. Okay. These answers are not marked by me. This is the wrong answer. Okay. Answer would be option number 4. Question number 13. What is the concentration of sodium hypochlorite commonly used as an irrigant in regenerative endodontics? Again, this is something that you have to remember, that regenerative endodontics, we are dealing with immature pulpless teeth. Pulpless tooth hai. Immature means it has a wide apex. Wide apex. So we use a low concentration of sodium hypochlorite. And it is in the range of 1.5% sodium hypochlorite. So option 4 would be the answer. This is something that you have to remember specifically for regenerative endodontics. Option 4 would be the answer. Please, someone told me 5.25%. No, 5.25% is the generally used for closed apex mature teeth. Immature teeth, so do not get confused. It is asking you specifically about regenerative endodontics. The tooth is immature pulpless wide apex. If you're using a high concentration sodium hypochlorite, it would seep in the periapical tissues, cause sodium hypochlorite accident that is caustic to the tissues. Okay, 1.5% should be the answer. Question 14. Which of the following uses fluorescence for the detection of caries at different levels? What is fluorescence? Quantitative laser fluorescence is a method. Okay. Diagnodent, quantitative laser fluorescence, fiber optic transillumination, and caries management by risk assessment. Now, I would say that this question is technically incorrect because I do not know whether these options are all correct or not. Quantitative laser fluorescence is a technique on which the device diagnodent is based. So this is the operating principle, and this is the commercial device that is available for diagnosis of caries. So both these options cannot be there because they represent the principle and the device. So both 1 and 2 are correct things. There must be some other option that is not correctly recalled over here. These are ruled out. Okay. Diagnodent is a device that is based upon quantitative laser fluorescence. Okay. The carious tooth structure is filled with water. It becomes porous, so it absorbs water. So there is decreased fluorescence as compared to an intact tooth structure. Okay. So this is known as device called diagnodent. Now, this device has a disadvantage that it has got low specificity. It is mostly used for the diagnosis of carious lesions on the occlusal surface. Occlusal surface. So if the question is asking you which areas diagnodent device that is based upon QLF is useful, occlusal incipient carious lesions as compared to smooth surface lesions. But disadvantage is that it has got low specificity. Okay, it is not specific for calcification caries. Whenever there is decalcification of the tooth due to any reason, it would detect and give the reading as being carious lesion. So it has got low specificity. It is not specific for dental caries only. That's why it is not routinely used and has not become very successful in the clinical practice. Although it is very, very sensitive, even a slight subtle difference in the mineralization of the tooth can be detected. So it has got high sensitivity. It can detect even the smallest, the most incipient caries lesion. It has got low specificity. Okay. It is not specific for dental caries. It can result in misdiagnosis. Question number 15. Which of the following is not a factor that determines the success of perforation repair? Another very good question. Not a factor that determines the success of perforation repair. Level of perforation, size of perforation, nature of perforation, and time elapsed between the perforation and repair. Now, what could be the answer over here? Level of perforation, success definitely is determined. These are the root. We can divide the root into cervical 1/3, middle 1/3, and apical 1/3. If there is a perforation in the cervical 1/3, it has got the easiest access and it has got most easy to repair. Okay. It has got easiest access. Definitely something that is more coronal is easiest access. It has got the most difficult access. But if we talk about prognosis, an important thing, the prognosis is worst for cervical 1/3 perforation and it is best for apical 1/3 perforation. Okay, so location of perforation is definitely a determinant. Another set of questions: which perforation is easier to repair, apical 1/3 or coronal 1/3? Coronal 1/3 is easier to repair. But which perforation is a better prognosis? Apical 1/3. Why? Why apical 1/3 is completely enclosed in the bone. Cervical 1/3 communicates with the oral cavity. There is seepage of gingival crevicular fluid. There is seepage of saliva that are laden with hundreds of bacterial species. So the chances of such perforation to successfully last over time is reduced as compared to more apical perforations. So definitely level of perforation affects the success. Size of the perforation, but obvious. Smaller the perforation, better the prognosis. So prognosis is inversely proportional to size of the perforation. Smaller the size, better the prognosis. Nature of the perforation, whether it is iatrogenic or pathological. Some pathology or by mistake of the treating dentist it has happened is of no consequence. Perforation is a perforation, whether it is pathological or iatrogenic. So this would not determine. Time elapsed between the perforation and repair, it is the most critical factor. Another question that can be answered. Okay. More than the size, more than the location, the most critical factor that would affect the prognosis of perforation even after attempting to repair is the time elapsed. Sooner we repair the perforation at any location, better would be the prognosis as compared to delayed repair. So always remember, whenever the question is asking you which is the most crucial factor for the prognosis of perforation, it would be the time. So this definitely affects size affects. Answer would be option 3. The nature, whether it is iatrogenic or pathological, has no effect. Okay. Okay, that was the last question. So this is all about today's session. Some very interesting questions were there related to the traumatology and post and core specifically I would tell about. So that was very technical. But in all, it was an interesting session to discuss with you guys. I hope it has been comprehensive enough and I have covered the related aspects also. So that is all for tonight from my side. Happy reading, best wishes. Till then, keep enjoying your reading, keep enjoying your subject. See you in some other future session. Goodbye, everyone. Thank you so much for being connected.